we got a few complications, especially stenosis. And because of a stenosis rate of about 40%, switched to another technique. And by that time, I had met Calvin Higa, started doing lots of manual anastomosis. But of course, that takes a little bit more time. And therefore, again, I switched to the linear stapler anastomosis with manual closure of the introduction defect. Right now, that's what we do. When we do Roux-en-Y gastric bypass, we perform a linear staple anastomosis, except in redo cases. In most redo cases, where we don't know for sure where the old staple line is, I'd rather do a manual anastomosis because I think it's a little bit more cumbersome. It takes a little bit more time, and I think it is safer, especially in redo cases.
Sir, we will go ahead and also because routinely I will ask question and we will go ahead. Personally, sure. I know and I think many of our viewers, because most of our viewers are bariatric surgeon, definitely they know you. But sir, again, we like to hear from your side, your brief introduction.
Okay, well, as I tried to say, I started doing bariatric surgery, laparoscopic bariatric surgery in 1994. Because, you know, the adjustable gastric band was introduced by my friend Guy Bernard Cadier in 1992, and I was there. And it took me a while before I myself started doing that, but in 1994, started doing laparoscopic adjustable gastric bands and did hundreds of them, but learned very quickly on that there was a lot of complications with that technique, and therefore I went and looked for other procedures. And in 1999, I discovered, if you will, the Roux-en-Y gastric bypass, laparoscopic version, based on the work of Alan Whitgrove. And so initially we did also circular stapled anastomosis by introducing the anvil through the mouth. And it went pretty well, but after a while, we realized that we had a high incidence of stenosis, of anastomotic stenosis, and therefore switched to different techniques. First, the manual technique, the hand-sewn anastomosis that my friend Calvin Higa taught me, and I must say he's a master at that. I'm not by far that good. But still, I did a decent job, I think. And but after a while, it took a little bit too long, and we started switching to the linear staple anastomosis that by that time was probably the most popular. By that time, I mean 2004, 2005, and that's a technique that I'm still using. Manual anastomosis only in redos because I think it's safer, since in redos you often don't know where the initial staple line is, and you don't want staple lines to cross. So therefore, instead of using a linear staple anastomosis, I prefer a manual anastomosis in redo cases. So that's briefly my story on Roux-en-Y gastric bypass. I should add that starting in 2007, I started doing mini gastric bypass or single anastomosis gastric bypass as well. But in specific cases where the patients do not complain of any type of reflux, where endoscopy is okay, where there's no signs of esophagitis, then I will be very keen on doing a mini gastric bypass or single anastomosis gastric bypass. So Roux-en-Y gastric bypass, I think, has about 25% of my practice right now. And I do that in patients who do not qualify for single anastomosis because any sign of reflux is present.
Sir, sir, if we go ahead, so because you have highlighted some technical points of your technique, we also want to know, and we interested to hear from your side that specific point that you did evolution in your technique, especially during more than 2 decades. Now you are doing Roux Y, and you are one of the pioneer. We see you like a pioneer of Roux Y gastric bypass. And so word no Himpen, he's a pioneer of Roux Y gastric bypass. Definite, we are interested to hear more about evolution. So which steps you have changed and why you have changed that? Like you have highlighted that circular, you have changed to like linear or others, and why you have changed. Yes, there was some restriction. So stricture. So sir, if possible, please highlight those specific points.
Yeah. So as I said, the problem with the circular stapled anastomosis, as we initially used it back in the late 1990s and early 2000s, the problem is that you depend on somebody to introduce that anvil through the mouth, because that was the technique that we used. And I know that Bruno Dillemans, for instance, does a small gastrotomy and inserts the anvil that way. But we used to do a peroral technique, a little bit similar to what Alan Whitgrove does. And we used an EEA, or I mean a circle stapler, I apologize, with a diameter of 25, because we thought that a smaller stapled anastomosis would indeed create more stenosis. And indeed, what we saw is that we had a 40% incidence of stenosis after that circular staple, despite the fact that we had a 25 circular staple that we used. So therefore, we switched to the technique of hand-sewn anastomosis, because it's easier with the hand-sewn anastomosis to shape the anastomosis, to vary the size of the anastomosis, because you don't depend on one fixed size like in a circular stapler. And so based on technique of Kelvin Higa, we started doing a hand-sewn anastomosis gastrojejunostomy. And that went okay, but of course it takes a little bit more time. That's one thing. And the second thing is that at that time we had lots of fellows and residents, and they had to be taught how to do an anastomosis. And I can tell you that a hand-sewn anastomosis demands a lot of practice. So therefore, because to make it more universal, if you will, we started doing the linear anastomose technique, which I think has been now taken over by almost everybody. And the technique itself that we used was, as I said, the linear stapled anastomosis with a diameter, a length of the anastomosis of about, I would say, 2 to 2.5 centimeters. Also, we used the so-called Brazilian technique, which means that we create the gastrojejunostomy just like a mini gastric bypass, and then transect between the JJ anastomosis and the gastroenteral anastomosis at the end of the procedure. Also, we very early on started closing the defects, Peterson's defect, mesenteric defect, and we started doing that in the early 2000s. And why was that? Because very early on in our experience, we were confronted with internal hernias. And an internal hernia is, I can tell you, something you never forget when that happens to one of your patients. And in the very early years, we did lose a few patients because of misdiagnosed internal hernias. And so therefore, very early on, I really put a lot of emphasis on closing that defect space of Peterson and of the mesentery. and still doing that, of course. Finally, in terms of the jejunal anastomosis, went through different techniques. I did manual ones, end to sides. And right now what we do is we do also a linear stapled mechanical anastomosis by and close the introduction opening by a manual suture of barbed wire. That's what we use now to close that introduction defect. And again, we do close all the defects religiously, I would say, because I think it's really, there's evidence that this is really a step that you cannot omit to do when you want to perform safe Roux-en-Y gastric bypass.
Sir, so much thanks, and really it is a excellent explanation, and in my opinion, excellent journey of Roux-en-Y gastric bypass with such a great surgeon. Sir, in your opinion, is there any age limit for Roux-en-Y gastric bypass, like in adolescents or in old age, like above 65, under 80?
Yeah, well, by law in my country, we cannot operate or perform bariatric metabolic surgery in individuals that are under 18. So the lower limit of age is 18. The upper limit, there is none. But we need to have, before we get the occasion to operate on a patient, we need to have a multidisciplinary consultation. And that's basically what's essential in the indications. So when the patient is considered physiologically too old, according to the committee, then we can do it. But officially, there is no upper limit for performing Roux-en-Y gastric bypass. So there is a lower limit, but not an upper limit.
Sir, why I am asking? Because in old age, there is more chance of malnutrition if we do a surgery in a patient above 65. So definitely there is more chance of malnutrition. So have you any experience of severe malnutrition in such a age?
No, and I must say that we do have malnutrition in some patients, but it's always in atypical bypasses. When we started doing, especially in revisional cases, distal bypasses, there we have seen nutritional issues. But with the way that we perform the routine Roux-en-Y gastric bypass, which means a pouch that is not very, very small, and also limb lengths that respect, I would say, the remaining bowel that is not being bypassed, we do not encounter usually any nutritional issues. However, when we perform distal gastric bypass, especially in redo cases for patients who did not lose sufficient weight after a regular Roux-en-Y gastric bypass, we have encountered a significant number of nutritional issues. And frequently, quite frequently, we have to go back in and deconstruct again the distal bypass and change it into a regular gastric bypass. And that's why I would highly recommend not to perform a distal bypass, also not in patients who have failed their weight loss journey after a regular Roux-en-Y gastric bypass. A distal gastric bypass is a dangerous operation, and it demands a very, very tight follow-up. But also, even in the most tight follow-up, you will see patients who will develop nutritional problems and malnutrition, and that's something that can be really deadly.
Sir, excellent, sir, and definitely your every word and every sentence is a guideline for all of us. Sir, what is your standard for BP limb in initial Roux-en-Y gastric bypass? Are you adjust this BP limb on the base of BMI, age, or comorbidities like diabetes?
Yeah, that's an excellent question. Well, I will give you a historical answer. Initially, what we did was we had an alimentary limb of 150 centimeters and a biliary limb of approximately 50 to 60 centimeters. But we saw, especially based on recent literature, especially coming from Holland, we learned that in terms of weight loss and in terms of comorbidity resolution, outcomes are better with a longer biliopancreatic limb. And so therefore we switched to a biliopancreatic limb of 150 centimeters. And I know that many people say it's too short and you need 200, but we use 150, and we use an alimentary limb of about 60 centimeter. What I would say, just sufficient to avoid reflux into the gastric pouch. So we do not depend on the metabolic problem of the patient right now. What we do is we try to stick to the standard and try to avoid trouble. And I think if we respect 150 centimeter and 60 centimeter, I think we will not run into trouble, at least not too often.
Thank you, sir. Sir, according to your protocol and your experience now, more than 2 decades of Roux-en-Y gastric bypass, not only your personal experience, just your journey, academic journey, and also promoting bariatric surgery, promoting Roux-en-Y gastric bypass. I have attended a lot of your international meetings, your lectures. So now at this stage in 2022, after these 2 decades, according to your opinion, relative and absolute contraindication of Roux-en-Y gastric bypass. So this is one question. And another with this, so is smoker is not good candidate for Roux-en-Y gastric bypass?
Well, again, good question. You know, the problem with smokers is marginal ulcer. And depending on the technique, a little bit of anastomosis. But when you look at the literature, there is an incidence varying between 1% and 15 or 16% even of marginal ulcers. And what also is clear from literature is that very often a marginal ulcer will go unnoticed. It will be there, but will go unnoticed for a long time until, you know, disaster strikes. So therefore, I must say that we do not perform a Roux-en-Y gastric bypass in my center when the patient is a smoker, is a heavy smoker. The patient must quit smoking or no Roux-en-Y gastric bypass. If the committee is okay to go on with surgery, then we do a sleeve gastrectomy on those patients because we, of course, don't have an anastomosis. There are other contraindications for Roux-en-Y gastric bypass. There's, of course, the patients that are drug abusers. There's the patients that psychologically cannot tolerate the type of procedure. There's patients that have a history of drug abuse. But then again, you know, it will be the committee, the multidisciplinary committee, that will pick that up and will tell us not to go ahead and perform these surgeries. Very important also is when you know that your patient does not have the financial means of buying supplements, vitamins, etc., then of course you can do a Roux-en-Y gastric bypass because those patients need to take vitamins and minerals for the rest of their lives. They also need to come on a regular basis for follow-up. They need to have their bloods drawn so that you can have a good idea about their biochemical evolution. And so when we're not 100% sure that the patients will satisfy all those requisitions, then we will not do a Roux-en-Y gastric bypass. Roux-en-Y gastric bypass is an excellent procedure, but you need a very strict follow-up. And there's a lot of literature on that, and our own experience confirms that as well.
Sir, so much thanks and a great message for our viewers, because now we are also live on Facebook group Global Laparoscopy and we have a lot of viewers there. Sir, what is your standard size of gastric pouch? Is size of gastric pouch is important because the main issue now after Roux-en-Y gastric bypass is weight regain, and also marginal ulcer. So this size of gastric pouch is important.
Absolutely, it is important. But I would like to refer to an excellent randomized controlled trial from Holland, where there's a 4-year follow-up and where we see that there is better outcomes in terms of weight loss when we have a pouch that is long, about 10 centimeters, and narrow, better than a pouch that is shorter and narrow. So it's quite of surprising, but it is an excellent study, and it's a randomized study, so it has a very high index of evidence. Now, what we must know, though, and you mentioned that briefly, is that the longer your pouch is, the more narrow it must be, because the volume of a pouch is very important. And there's a paper that was published by the team from the North Carolinas with Abderrahman Numeri, where they found that for each, I can be mistaken, but I think for each 1.5 centimeter to the third increase of pouch, there is a so many times fold increase of marginal ulcers.
Yes.
So we're stuck between two things. We need to have a pouch that is long enough, but also narrow enough so as to provide good weight loss, but also avoid the incidence of marginal ulcers. Another point that's important is the gastrojejunostomy. There's no conclusive literature on that. In our experience, what we do is with that linear technique that we use a diameter of about 2.5 centimeters. I don't think it should be much bigger than that for two reasons. First one is this weight loss, but also it's dumping. You don't want to have food that dumps into the small bowel and creates all the symptoms that we know. So therefore, we try to keep the size of that gastrojejunostomy rather down, rather than make it too big. Unlike in single anastomosis gastric bypass, where we make a wider anastomosis in an effort to avoid possible reflux. So the gastrojejunostomy is important, and to make sure that we avoid as much as possible dumping and still get good weight loss, I would say 2 centimeter is a good size. And actually, when we look at the literature from France, for instance, we see that that's really a critical size, is that 2 centimeter diameter. And actually trimming a gastric bypass, which we almost never do, but in France they do it as soon as they notice that the gastrojejunostomy is bigger than 2 centimeters. And also when they have a volume of the pouch that exceeds 200 cc's. And in order to find that, to diagnose that, we now have those excellent tools with the 3-dimensional CTs. And we very liberally use that. And I think when that really helps you demonstrate that the anatomy of your gastric bypass is okay. So when your patient is gaining weight and the anatomy is okay, then you have to look into other issues than the strictly surgical ones to correct that.
Sir, thank you. Sir, I have one question. Before PPI era, when there was no proton pump inhibitors, I remember at that time, one of the treatment of gastric ulcers or peptic ulcers was vagotomy, highly selective vagotomy, or we did, and many times I remember at that time. So now what is my question? My question is about marginal ulcer. What do you think the cause of marginal ulcer is? So high production of acid or foreign body in that area. Why I am asking foreign body? Because you have also experience of manual gastrojejunostomy, and definite at that time you suture with absorbable suture. Have you any comparative study between these two cases? So cases with hand sewn absorbable and with stapler, because stapler titanium and foreign body, and comparative study for marginal ulcer and role of vagotomy.
Yeah. Whoa, that's a lot. Well, the marginal ulcer issue for sure can be prevented to a large extent by the use of PPIs. And there's studies on that, and we can say that almost half of the marginal ulcers will not appear when patients are on PPIs for a longer time. What's a longer time? Usually, the literature speaks about 90 days perioperatively. Now, what is the reason? So that really seems to hint towards a role for acid in the pathogenesis of marginal ulcer. However, you very rightly stated that there is a foreign body reaction that may induce the problem of marginal ulcer as well. And to tell you the truth, when we have a patient with a recalcitrant marginal ulcer that needs to be operated on, and we redo the pouch and the anastomosis, we will avoid the use of staples and do a maximum of hand-sewn suturing with resorbable material so as to avoid that foreign body issue. Another thing is that the fact that patients develop marginal ulcers can also have to do with ischemia. So again, to answer one of your earlier questions, smokers should not get a gastric bypass by Roux-en-Y technique because of that very reason. And therefore, there's acids, there is ischemia. Those are two things that must be avoided. Vagotomies, I don't believe in that so much, and I cannot, clearly tell you we didn't do any Congo red studies or anything on the mucosa of the gastric pouch to demonstrate the absence or presence of acid in the small gastric pouch. However, the way that we make our pouches very narrow, the fact that we also avoid the angle of His and we stay very close to the esophagus, the fact that we transect everything, I can assure you that very few vagal branches are left that could create an acid production in the small pouch that we have.
Sir, so much thanks, sir, because now the main issue after is Roux-en-Y gastric bypass is marginal ulcer. There is no doubt. So
That's true.
always we talk about this, and definitely you did a lot, and your colleagues and persons like you. But because we all are for humanity, and when we have started bariatric surgery, so bariatric surgery with less complication. So during these 2 decades, I like to hear from your side what you did technically to reduce the chance of peptide, this marginal ulcer. So this is very important for us to, yes, you highlighted size of pouch, so pouch must be narrow. Then when pouch will be small size, then there will be less acid production, less chance of marginal ulcer. There is no doubt. So technically, so which points you did, and or it was successful during this 2 decades? You see, we are when you were in 2010, so now 2022, what was the progress to reduce marginal ulcer?
Yeah, well, the biggest progress that we made was you want to be very, very, how would I say, very, very precise in what you do. And to be very precise, to be able to construct a pouch as we just discussed. To do that, you must be in very comfortable circumstances. And what I think is the most significant progress that we made was to put our patients on a 1-week preoperative protein diet. Why is that? Because when your patient is on a very strict radical protein diet without sugar for 1 week, you will see that the liver will, in all cases, not in most, in all cases, the liver will be nice and firm and will allow to be retracted very easily, which gives us perfect visual conditions on the upper part of the stomach. And also, we see that the fat pad, for instance, will be much less aggressive in patients that for a simple 1 week protein diet will have obtained that. I mean, this was, to me, was really a cornerstone in better outcomes in our patients. And indirectly, because of better vision, better working conditions, more, I would say, accurate ways to do our dissection and our anastomosis, we could therefore avoid largely the issue of marginal ulcer. And also, we learned the hard way again that we should put all our patients on PPIs for about 3 months.
Sir, excellent. Sir, one thing, so definitely you also face such a situation. Personally, I have also faced same condition, because in Dubai, so we deal multi-ethnicity, as you know, so also we have vegetarian, we have high protein, everything. But personally, I see same patients, same ethnicity, same about BMI, same technique, but in some patients, and also protocol, everything, PP, everything was same. But in some patients, there was marginal ulcer, no smoking, nothing. So maybe they have, I have no idea. This is my question. Really, I don't read about this. So maybe there is more acid production in those cases. Can we evaluate pre-op in such a case? So parietal cell, or I have no idea. We can discuss in future. Is it possible to think about this? Then we can also, when there is chance of or we can do, in some cases they are suffering with marginal ulcer, we can check acid production. So parietal cell, if high in future, yes, we can highlight these. This is more chance of marginal ulcer. So you can go for sleeve gastrectomy. It's better.
Yeah, perhaps that's a possibility to the future. But I say that, you know, there is some literature on that, on the perfect evaluation preoperatively of acid production in the to be operated on stomach, etc. But routinely we don't do that, and we just stick to the simple rules of no smokers and keep the pouch the way we discussed it. And also, I think it's important to use a good surgical technique. We know that, for instance, the longitudinal linear stapler has half the incidence of marginal ulcers compared to the circle stapled anastomosis. So I think surgical technique is important as well. So it's not only just smoker and acid. We also need to have a good technique to avoid marginal ulcerations. But again, marginal ulceration is a very annoying complication, and it can originate into gastric fistula. We just had one last week, despite the fact that the patient was on PPIs and the whole thing and was not a smoker. So perhaps indeed we should be able to foresee that and to choose another type of surgery rather than the Roux-en-Y gastric bypass in those particular individuals. And so, yes, you're right. Maybe it is interesting. It would be interesting to select those patients out that have too much acid production in their parietal cells and not submit them to a Roux-en-Y gastric bypass. That's a good point.
Thank you, sir. Sir, we have a lot of questions also on Facebook, and many of questions are also related to marginal ulcer, and most of them automatically. So you have answered, and hopefully my viewers, you are satisfied from this question. If you have any question, please add. Sir, regarding pre-op endoscopy and H. pylori eradication, so what is your protocol? And we are really interested to hear from your side.
Yeah, all the patients that are candidates for bariatric surgery, no matter what type of bariatric surgery, do undergo a upper endoscopy. Not only to diagnose the presence or absence of H. pylori, but also to evaluate the possible hiatal hernia, the presence of Barrett's esophagus, which is sometimes totally unexpected, And so all the patients do undergo preoperative endoscopy. As a routine, postoperatively, they only get endoscopy in case of symptoms, which may be a mistake, but that's what we do. And we do a endoscopy at 1, 3, and 5 years in all patients who had sleeve gastrectomy and all patients who had single anastomosis gastric bypass, but not in Roux-en-Y gastric bypass, again, except in those who have symptoms that might be suggestive of a marginal ulcer.
Sir, regarding you have highlighted H. pylori eradication, that is your routine practice. My question, so definitely you have deal marginal ulcer after Roux-en-Y gastric bypass. Have you any study all of these cases who are suffering? Because really marginal ulcer is an issue. They were also positive for H. pylori before surgery. Have you any study on these special cases?
No, but I can tell you that we only perform Roux-en-Y gastric bypass on patients that are H. pylori negative. So the H. pylori must have been eradicated, otherwise they don't get a Roux-en-Y gastric bypass.
No, my question. Sir, my question, yes, patient is H. pylori positive, you eradicate, now negative, okay? We know, but can we collect the data? Maybe it will be helpful. So you can ask to any of your resident or fellow. So these are 100 or 20 cases of, or some cases, X cases of marginal ulcer. So just search in past data, how many percentage of these cases, those are now marginal ulcer, were H. pylori positive? And another question, in these cases, when marginal ulcer is positive after surgery, have you checked H. pylori again in these cases?
Yeah, we do. Of course, H. pylori is systematically checked in all cases where an endoscopy is done. The only way we check H. pylori, though, is with endoscopy. We don't do any, at least not routinely, any analysis of H. pylori in stools or anything. But what we do with the endoscopy. To answer your question, do patients who previously suffered from H. pylori who had eradication, do they develop a marginal ulcer? I can't answer you that. I don't have the data. It may be worthwhile to look into it, but at this stage, I cannot answer that.
Sir, regarding this, so this H. pylori, so which percentage of your marginal ulcer cases were H. pylori positive? Because you did endoscopy and they were, have you any data?
No, I don't have any data. But we, as I said, we do check everybody. If they're H. pylori positive, we do an eradication. We recheck those patients with a breath analysis to see if the parasite is gone. And only when the urea breath test is negative, then we perform a Roux-en-Y gastric bypass. If the breath test remains positive, then we will switch our strategy. And except when there's a contraindication, we will perform a sleeve gastrectomy rather than a Roux-en-Y gastric bypass.
No, sir, I understand that one. So what is my question now? My question, yes, I am not asking H. pylori pre-op or before surgery. My question is this. Now patient after Roux-en-Y gastric bypass consulted with and diagnosed. Now you diagnose marginal ulcer because you routinely do endoscopy in this case.
Yeah.
Which percentage of these cases were H. pylori positive now? Have you any data?
Yeah, we do have data on that, but that's very low. I think it's less than 1%.
It means H. pylori is not important.
Not important in our population. Don't forget, it's not endemic as in other countries. I think that the population incidence, I'm not talking about bariatric population, but the overall population in our country, H. pylori should be less than 10% of the population.
Another question, because now we are in Dubai and you know better than me. So till every procedure, we need approval from insurance. So this is not like a package, okay? And also people here, they are also little, they are not friendly with the upper endoscopy because routinely you do upper endoscopy in all of your bariatric surgeries. So which percentage of your cases you have changed your decision due to endoscopy?
Yeah,
This is
but I think that's a wrong question. And I know that's what the insurances will ask you. Why do you do that? Because it will hardly interfere with your decision making. That's not the point. We do the endoscopy because we want to make sure that in future we will not miss anything. And the best example is, of course, the Barrett's esophagus after sleeve gastrectomy. It's not within the scope of this discussion here, but at least if we don't have preoperatively a diagnosis through endoscopy of any abnormality of the GI tract, then it's worthless. So therefore, when we do an endoscopy, it is really not it's usually not to indicate what type of surgery we'll do, except for some exceptions, but it is to give us an idea about what we have to look for in the future years to come in that very particular patient. So therefore, change the strategy of bariatric surgery. Of course, it can interfere sometimes, and we gave the example of the H. pylori resistance that will change the decision of Roman gastric bypass into sleeve gastrectomy, for instance. But usually, as I said, endoscopy is important because we want to have full documentation of the status of the patient, and that we will know what we talk about in the years to come, depending on what the procedure was. And don't forget, with all the medication that are coming now, the PPI that we already mentioned, the type of surgery, there's a lot of variables that will have to be taken into account in the future years. And when we don't have an endoscopic basis to begin with, I don't think there's any way that we know what we're doing.
Sir, excellent and strong answer, because I have this question from one of my colleagues from Middle East. So due to this, I highlighted this because he highlighted this issue. Sir, regarding this hiatal hernia, already you have mentioned about hiatal hernia. Just imagine this paraesophageal hernia, a large size hernia. So are you repaired in Roux-en-Y gastric bypass?
Yeah, well, that's
Also,
I don't,
we have
do,
youngsters. They are youngsters viewers. Yeah.
Yeah. Well, I was very, very positive that you had for any type of bariatric surgery, you had to dissect the hiatus completely to rule out any possible hiatal hernia, a prehernial lipoma, even whatever. But what I also learned was that despite the fact that we went on and dissected all hiatuses that we encountered, we really very often had a recurrent hiatal hernia, or worse, we had hiatal hernias in patients who didn't have one to begin with. And the reason was that we dissected all the ligaments, and that's something you should not do. So therefore, I think it's important when you have a hiatal hernia of decent size that you must dissect it, of course, but you must repair it, obviously. But you have to limit your dissection, unlike what you would do in a typical reflux case. So and what I try to do is I try to limit my dissection to the posterior aspects behind the esophagus, if you will, dissect the bottom of the hiatus, approach the crurae, and that's it. I try to avoid, by all means, the phrenogastric ligaments, because I think that is something that's really essential in avoiding and preventing recurrent hiatal hernias. So to answer your question, hiatal hernia, when you see it, you fix it. When you assume there is one, you dissect it minimally and you fix it. But when there's only small indices that there is a hernia, don't touch it.
Sir, so much thanks, sir. So as you have mentioned, so in all of your cases, especially because we are now talking about Roux-en-Y gastric bypass, this is your routine to dissect and to find any type of hiatal hernia.
It used to, but again, we learned the hard way that we did more harm than good. And so therefore, what we do now is only in those cases where there is an obvious hernia or where we suspect a hernia preoperatively because of the endoscopy or perhaps even the manometry, then we do we fix the hiatal hernia. But again, with minimal dissection, we try to limit our dissection to the posterior aspect and stay away from the phrenogastric. Of course, when you have a huge hiatal hernia, that's impossible. I know that too. But I'm talking about the cases that we very often see, the dimple. And in those cases, try to stay away from the anterior aspect and stay posterior, close it, and get out.
Sir, so much thanks. Sir, regarding this closing of defects, because again, this is I know, because why I am asking these questions. So many of our viewers in this setup, they are also youngsters, they know about basics, why, what happened, like these things. Because due to this, I know these are some questions that are really not important, but they want to hear from your side. So have you any experience of internal hernia after closing defect? Are you closed routinely and have you any experience?
We have been closing the defects for the past 20 years. And I should say that we have no internal hernias, but that would be a lie. We still have them. The only thing I can say is that it's less frequent than when we don't close it. When you look at the literature, it's about the same thing. You just, instead of having an incidence after 10 years of 10% of internal hernias, when you close them, you have an incidence of 4 to 5%, but it's never zero, trust me. And why is that? Because it depends on your technique, of course. But I think even when you have a good technique, and I reviewed cases where I think the closure was perfect, well, those patients still developed an internal hernia. And especially when there is an aggravating factor, like a pregnancy, for instance, remember that even though you did an excellent job in closing the defects at the time of the gastric bypass, when there's a pregnancy because of the increased pressure intra-abdominally, there is a higher incidence of internal hernia. And again, that's a potentially lethal condition. So even though the closure has been done, it does not 100% rule out the incidence of an internal hernia.
Sir, according to your experience, so interrupted suture or pierced suture is which technique is more effective?
I think if you try to picture what happens when a patient loses weight and you have closed the internal hernia defect, when you have separate stitches, you will create buttonholes and you will have openings where, of course, a small piece of bowel can herniate through. When you do a running suture or even a purse string suture, I think the chances of developing an internal hernia are better. So therefore, I use non-absorbable material. Right now, I use very easily, I use the barbed wire, but I use a running suture or even a purse string, never separate stitches. And that's what I have against the staple closures. I really think that there's a good chance that you will create openings in between the staples, and that's where you will have an internal hernia. Yeah.
Thank you, sir. Sir, during this your journey of Roux-en-Y, that is more than 2 decades, have you faced any intractable marginal ulcer after Roux-en-Y gastric bypass, and what you did surgically for these cases? There's no response to PPI, medicine, nothing. What you did?
Of course, for instance, we've had cases with a perforated marginal ulcer, and there's two techniques. The first one is to do an omentoplasty and get out. And another technique, what I think is more prone to complications, but which I think at the base is a better technique, is to reshape completely the pouch and reshape the anastomosis so that you basically get a completely new situation. The issue of ergonomy, we dealt with that earlier. I personally don't believe in it that much, but I agree that it's probably worthwhile to look into it and to try to preoperatively decide if the parietal mass is too significant or not. But I have no conviction on that.
Yeah. Sir, have you faced any, just I can ask, intractable also nizidoblastosis after Roux-en-Y gastric bypass?
Nizidoblastosis. I remember one case in the many hundreds, and I can tell you that that was a very interesting case, by the way. It was a patient with very intractable dumping, and we had considered in doing a reversal of the gastric bypass, and therefore we did first a feeding gastrostomy, fed the patient through the gastrostomy, and we wrongly thought that everything was okay and that the patient did not suffer from dumping by feedings through the gastrostomy. But I must say that we didn't look sufficiently into it. And we missed the diagnosis because when we reversed that patient, she developed again dumping, and that was based on an insulinoma. And I know that's not the same as nesidioblastosis, but it's of the same family. But through nesidioblastosis, which is a vast proliferation, if you will, of beta cells, I have not personally encountered it, but I know there's a chance that you may run into it.
Okay, sir. Thank you. Sir, one of the another issue after Roux-en-Y gastric bypass, and also we have a question from our viewers regarding which percentage of your patients are suffering with weight regain after Roux-en-Y gastric bypass, and surgically, when you're going to treat surgically, which technique you prefer? This is also a question from our viewers.
Yeah. Well, according to the literature, when you have weight regain after a bypass, you have to check the anatomy. When you have a volume of a pouch that is around 200 cc's or more, then you can go ahead and trim it. When you have an anastomosis that is way beyond 2 centimeters, 3, 4, 5 centimeters, then you can go ahead and trim it. Another option is to place a usually non-adjustable band around the pouch so as to reduce the compliance of that pouch. Another possibility is to go and change the regular bypass into a distal bypass, but as I mentioned earlier, we no longer do that because of the metabolic complications that we get with that technique. So finally, when we have an anatomy that's acceptable, there's no real flaw that we can detect on the construction of the bypass. What we do now is we switch to the use of GLP-1, which is semaglutide, 1 injection a week, which gives quite good results. But for that, we have to make sure that there's no obvious flaw in our construction of the gastric bypass. If there is, you have to address that first. If there isn't, then you can switch to medication.
Sir, are you prefer distalization?
Nah, abandon that. We did lots of it, and well, unfortunately, I didn't publish that, but I presented that. I think it was at the IFSO meeting, and we had an experience of, I think it was 35 patients with a distal gastric bypass. What's a distal gastric bypass? It's a rule limb of 150 and a common limb of 150 to 200. Okay, so we had an active limb of about between 300 and 350. Well, when we do that, we notice that very often patients do okay, they lose weight, they're happy and everything. But then all of a sudden, after a year, 2 years, 3 years, they kind of lose it and they become malnourished. They get edema, they get kwashiorkor, or you name it. And you have to reconvert them again, which is really a sorry thing to say. And so I must say that I very much I'm against this technique now, and it's too dangerous, and I never do it anymore.
Sir, so much thanks. Sir, earlier you have mentioned now in your practice, 25% is belongs to Roux-en-Y gastric bypass. And during this journey, definitely you decrease Roux-en-Y gastric bypass. And maybe in place, so now Anastomoses or other procedures. What's my question? What is your main concern after Roux-en-Y gastric bypass?
Internal hernia.
Internal.
Yeah.
Other than
And
not marginal.
that's well, marginal ulcer is some, and I know that marginal ulcer can be very dangerous, can get bleeding, perforation, etc. Very often they go unnoticed. Up to 50% of marginal ulcers go unnoticed, and the real incidence is probably 20%. I know that, but that's something that you usually can deal with medication, and you can when you do an endoscopy, you see it, you can treat it endoscopically, etc. You have medication that's pretty potent nowadays. But an internal hernia in a young patient who's pregnant and goes to St. Elsewhere Hospital, where nobody has ever heard of an internal hernia, and they lose the baby, the mother dies. I mean, that has happened too often. And even in my own experience, I know immediately 4 or 5 cases like that in patients in whom I was sure I had done a good job in closing the defects. So you're never sure that an internal hernia will never appear. And as I said, that is a lethal condition.
Sir, can I ask, so this is the main cause that you have decreased Roux-en-Y gastric bypass in the practice? Okay, sir.
Yeah.
Sir,
this and pain. There's also a certain number of patients, between 10 and 20% of the patients that show up with pain, unexplainable pain, that doesn't respond to anything. We submitted them to laparoscopy to rule out an internal hernia, but then we didn't find anything. We treated them with PPIs, we treated them with spasmolytics, you name it, but still they come back with unexplainable pain. And that's something that is also a very annoying situation.
Sir, is it possible this annoying pain is gastritis of remnant? Because when we do this is bile gastritis, because bile is always in that remnant. Because when we do Roux-en-Y, all that way is open. But when we do one anastomosis, that is narrow. Maybe the chance of bile in remnant is more in Roux-en-Y, and the cause of pain is it possible?
Well, there's literature on that. There's a paper, I think, coming from the US, where they they did the resection of the remnants specifically for that, for the bile reflux into the remnants. And we know that, for instance, in patients who had a concomitant gallbladder resection with the Roux-en-Y gastric bypass, up to 80% of the patients really have pathologic biliary reflux into the remnant. So this could be a reason or a cause for pain, but still, very often, when you can rule out the biliary reflux, you can do that with isotopes, of course. Then even then, that's a clinical condition that can occur, and that is very, very difficult to deal with. And that is also very tough on the patients, because they have patients that are really hooked on painkillers because of that.
Sir, so much thanks. And now, because 1 hour has been completed, and really I like to talk more and more, because this is a golden chance for myself, and personally I have learned a lot. So much thanks, sir, for your support. Really, we need your support. Sir, your message for youngsters who are just now going to start bariatric surgery or Roux-en-Y gastric bypass.
Well, my advice would be, don't stick to one technique. Not only Roux-en-Y, not only single anastomosis, not only sleep, but try to master a number of techniques, because you cannot fit your patient to your technique, but you have to fit your technique to the patient. That's one thing. And another thing that I would really like to stress is, please learn to suture. Learn to suture in all occasions, because sometimes, even in the most routine cases, sometimes you have, when you get into trouble, you will need to suture, and if you don't master that technique, you're lost. So those are my two main advices to the youngsters.
Sir, so
Well,
much
thank you.
thanks. So much thanks, sir, and so for your time, and thanks, viewers. And we will continue our series of Ruan by Gastric Bypass at next Tuesday, 10 p.m. Again, we will be with another legend of bariatric surgery, and we will continue this series of Ruan by Gastric Bypass till June 2022. Every Tuesday, 10 p.m. Dubai time, we will be live. Sir, again, so much thanks. Really
You're very
appreciable,
welcome.
and see you soon.
Thank you, and I see you soon. Bye-bye now. Thanks for inviting.
Thank you, sir. Thank you, sir.